Good afternoon, everyone. Welcome to the report launch for CfJJ's latest release, Just Healthcare, an overview and analysis of healthcare delivery in the Massachusetts juvenile justice system. This is an important examination of healthcare policies and practices that affect youth and older adolescents who find themselves incarcerated in Massachusetts. This report especially focuses on the need for a community standard of care in these settings. CfJJ, as a part of our research and public education work, often examines and addresses issues that impact young people in the deep end of the legal system. And today we uplift healthcare delivery and its impact on youth justice. Research is clear that poor health is correlated with crime and delinquency, meaning that access to quality health care for young incarcerated people is necessary, both for positive youth development and ultimately for greater public safety. Today, we'll learn about the community standard of care, why it's important, and hear findings and recommendations for how systems that provide care for young people in locked facilities can ensure that these important needs are properly met. In addition to hearing from CfJJ's Josh Dankoff, the lead author of the report, we will also hear from two pediatricians, Dr. Elizabeth Barnard of UCLA and Dr. Destiny Tolliver of Boston University and Boston Medical Center, both of whom have extensive research and practice experience providing and improving care for young people in locked facilities. We will also have the pleasure of hearing from Representative Dr. Greg Schwartz, who is the sponsor of House 285, an act relative to healthcare quality for children and youth, which is currently before the legislature's Joint Committee on Children, Families, and Persons with Disabilities. This bill addresses the need to cement a community standard of care in our general laws. A quick reminder that the report is now live on CfJJ's website, so I encourage you all to go to www.cfjj.org/publications to download a copy. With that introduction, I will now pass things on to the report's lead author, our own Joshua Dankoff, CfJJ's Director of Strategic Initiatives. Josh?
Thank you so much, Leon. And thank you everyone for coming today. It's a pleasure to see so many names and faces that I recognize, as well as some who I don't. So welcome. Just very briefly, if you're new to CfJJ, just want to let you know that CfJJ is now more than 30 years old, the only independent nonprofit organization working to improve the juvenile justice system here in Massachusetts. We look at the entire system, including a number of feeder systems, child welfare, school to prison pipeline. Although today's report is really looking at deeper end systems with the intersection of youth at DYS, the Department of Youth Services, and healthcare delivery there. The pillars of our work are advocacy, research, public education, and community engagement. And today really cuts across all of those themes with presenting research and advocacy. As Leon already mentioned, we've got a bill. As mentioned, we're going to hear some the report findings and recommendations. Really pleased to have Representative Schwartz, and then a discussion with two really esteemed doctors and researchers who know a lot about this space. And if you have questions, please feel free to drop them into the chat, or when we will have some time towards the end to have some question and answer with our guests. So first of all, why is this important? Why have a report about health care delivery for young people who are locked up? Well, healthcare matters, but there are often coverage, access, and community gaps nationwide. As Leon mentioned, poor health is correlated with issues of crime and delinquency. And while there is a standard of care, a constitutional standard for healthcare for incarcerated people, that is quite low. It's based on the Eighth Amendment, cruel and unusual punishment, and that standard is just deliberate indifference. So we have an opportunity, and the state really has an obligation to young people in its care and custody to do better than that. And just briefly, our methodology for this report, we put together a number of public records requests to agencies, did a series of interviews with both professionals and families and young people, and appreciated the opportunity to do a site visit at Department of Youth Services specifically focused on this question of health. So I'm going to do my best in relatively quickly to run through some findings here from the report. The first finding is that here in Massachusetts, the Department of Youth Services is using a community standard of care, which we applaud, but that where that is written down, the place where that is articulated is not in legislation, and it's not in DYS regulation, and it's not even in DYS policy. That the place where that's written is only in the contracting process that DYS has with healthcare providers. So it's in the RFR, the request for responses, which does set the standard of care as that for health, as that for the larger community. And the DYS contracting process even goes on and mentions that health services need to adhere to the AAP, the American Academy of Pediatrics, Bright Futures guidelines, which is a pretty strong, very strong standard of care. And just to mention that the young people who we spoke with confirmed that DYS is doing a strong job. DYS puts their money where their mouth is. They contract with nonprofit providers and provide a high level. Just to mention some of the highlights from young people. One young person said that their healthcare that they received while at DYS was phenomenal, and that it made them feel like they were the first priority. And one other person mentioned that that the healthcare services at DYS also respected their religion and culture. Another finding that's important to note is that around how the system actually works, how young people receive care who are at DYS. So DYS contracts with 5 nonprofit healthcare providers, not for-profit entities, and they fund these contracts for young people who are at DYS, inside DYS, either pretrial or committed. The funding mechanism for their healthcare is through these contracts with DYS, between DYS and these health providers. So inside these inside DYS units, there are health service units that are basically primary care facilities set up. And it's important to note that the nonprofit providers that DYS is contracting with are very strong. In the Boston area, it's Boston Children's Hospital. To use an example, in the Worcester area, it is UMass Medical. So these are hospital systems that have really high standards and are really staffing up using excellent people. It's good to know that the staffing ratios are very strong, that the facilities average about one health staff to 10 people who are incarcerated. And hopefully we can have some commentary later on how that is in line. We think that's in line with the NCCHC, National Correctional Healthcare Juvenile Standards Commission on Healthcare Juvenile Standards. It's also important to note that for young people who need care at a hospital, they might be in DYS custody, but if they need care at a hospital after that is possible, and that is paid through Mass Health. So one thing that really sets Massachusetts apart, and I think is worth saying, and this isn't specifically a DYS policy, but young people at DYS, they keep their Mass Health, or they have the opportunity to keep their Mass Health insurance in place. And even though there's a federal inmate exclusion for people who are incarcerated to lose, the state is not able to get federal reimbursement for those dollars, that the state has set really an excellent policy to keep young people on Mass Health during this time. Um, Wanted to just the next thing to talk about is the DYS continuum of care, and that DYS really aims to ensure comprehensive health services through two program models. One for pretrial detention for young people who are at DYS in a pretrial setting. And the average length of stay is just under 70 days. And that the what young people receive there are urgent and stabilization care, which is contrasted from the treatment programs, young people who are committed to DYS, who receive a more comprehensive assessment, chronic disease management, and preventative care. And just to note that substance use disorder for committed youth, that there's assessment there based on risk factors, and then young people are either put on a treatment or prevention track. So the legal authority that a young person, that DYS has based on if a young person is pretrial or committed is going to dictate the level of care that they receive, but overall it is a community standard that for both. DYS takes on a case management role and aims to connect young people to connect the care that young people received at DYS facilities to care that they'll receive outside of the facility. So there's, young people at DYS almost all the time are returning to the community, often even during their time during DYS commitment. And DYS makes an effort to make those connections with community-based healthcare providers. And there is an opportunity, I think, for improvement within this. Specifically, while this report does not focus on, focuses more on physical health than mental health, for young people who are in pretrial settings and are facing rather serious charges, there have been some reports of young people facing barriers to accessing mental health services in that pretrial setting, again related to DYS's legal authority for holding on to a young person. It's important to talk about, so if you've heard a theme so far, it's that DYS is doing a pretty strong job in terms of the contracting structure, in terms of setting a strong standard of care. And it's important to put this in contrast with some of the policies and practices that differ from those in the adult system, specifically focusing on the Department of Corrections here. And the report goes into more detail, but I just want to talk about 4 things here that are real differences between the juvenile and the adult system that really point to how the juvenile system is stronger here. First of all, the DYS does not use a capitated model for its contracting with healthcare provider. A capitated model basically would say if that the health provider gets a certain number of dollars per day per person who is incarcerated. And the problem with that model, or a problem with that model, is that it can incentivize not actually providing services because those payments are already made to the healthcare provider, and then any services that they're providing actually can be dollars that they're losing, and so it creates this this perverse incentivization to not provide services. Again, DYS does not do that. They have a strong staffing model, and the nonprofit entities are providing the services, and are not incentivized not to do that. They're incentivized to provide strong services. Another main difference is, as I mentioned, DYS youth stay on Mass Health. And this isn't a policy of DYS. This is sort of within Health and Human Services. DYS is an agency within the Health and Human Services. But for adults, that is not the case. They are either they're Mass Health. If they were on Mass Health and they get incarcerated, they become incarcerated. Their Mass Health is often suspended, especially if they're there for more than 1 month. And that has a lot of implications for what services they qualify for, and then also for the return to the community afterwards. I want to just also note that DYS contracts with the nonprofit providers. By contrast, DOC and many of the houses of correction are also contracting with for-profit health entities that have a profit motive that is not necessarily in line and not in line with providing excellent care. And then, as I mentioned, the DYS's community standard of care that they're using in their RFR process, not yet in legislation, is much stronger than DOC's. DOC, in its most recent RFR, also claims to use a community standard of care, but their definition of that community standard is only in reference to other incarcerated individuals and not the broader community. So it is a much weaker, even though it's using the strong word community standard of care, their definition is much weaker. If we look how this looks and compared to other states, the Massachusetts system is pretty strong. There are a number of systems nationwide that lack clear standards, and many are using privatized models that prioritize profit over care. But as I mentioned in the beginning, it's important that this community standard of care is not just in this RFR process if we want to make sure that it's durable. There are some concerns that we mentioned in the report. One thing is that DYS routinely shackles young people during their clinical and hospital settings, and that this is mandated by DYS policy around transportation, and often the shackling continues throughout clinical visits. There's DYS policy on this, and there are also specific hospital policies on this issue that can be vague, and the conversation and communication and alignment between those policies, between hospital policy and DYS policy, differs, and we've heard stories that there's room for improvement here. And it's important to note also that DYS is considering policy change in this area, and we certainly support that. Whoops, to go back one. I'm not going to do a deep dive into the recent changes in federal Medicaid policy, but it's important to note that two things have come up that do impact carceral health in this area, and that this is an opportunity for Massachusetts and all states to really consider and strengthen their health policy and commitment to providing strong health. So first, the Consolidated Appropriations Act, which is federal law from 2023, strengthened screening and diagnostic services for and the possibility of reimbursement using Medicaid dollars for reimbursement for care in the months prior to release from both adult and children. And there are opportunities that states can opt in to doing that for all people pre-trial, and that's certainly something we hope Massachusetts will do. Massachusetts also has a section, what's called a Section 1115 demonstration waiver, which again enables reimbursement for and Medicaid reimbursement for some services, thinking about reentry especially, and the connecting people to healthcare providers and having reimbursement for a range of services in the weeks and months prior to release. And for the most part, because DYS is already doing what they call EPSTD, early periodic screening, diagnosis, and treatment, for the most part, Massachusetts DYS is in line with the sort of better practices around Section 1115. But it's really important that, especially in the adult system at the jails and DOC, that things come in line and that the systems are considering the Section 1115 waiver, because it increases the eligibility groups for up to age 21 and for former foster youth up to age 26. So there's a lot there. I'm not going to try to talk about it more right now, but it's important that in this context we consider what Massachusetts can do to be the strongest in this area. Okay, I just want to mention a couple of recommendations, and then we'll move on to the next portion of our presentation. Um, the healthcare for incarcerated youth in Massachusetts is relatively robust, but it's important to note that there are still improvements that can be made that help ensure that a community standard of care is provided on the long term. And we also have a number of recommendations, not just to DYS, but that consider the adult system, and for the first time for CfJJ anyway, recommendations towards mass health, as well as academics and policy researchers. So first, a series of recommendations to the state legislature. We think it's really important that the legislature codify this community standard of care language into legislation and use and put current medical guidelines into the legislative framework. And there is a bill, an act relative to healthcare quality for children and youth, House 285, Senate 169 in the current session, that would do just that. The reason to legislate this is to make sure that this community standard of care is continued on the long term, right? Having language in the RFR process or even in policy could get overturned just by the signing of a pen of one person within the agency. We are not concerned that that's going to happen right now at DYS, but to make sure that that doesn't happen, and in light of the fact that DYS is already doing this work, passing a law like this to put community standard of care into the legislative framework would help ensure on the long term that young people receive the care that they deserve. We also think that given these differences between how the DYS system and the juvenile system and the adult system look, that raising the age of juvenile jurisdiction to include 18 to 20-year-olds in the juvenile court would extend the stronger care that we see at DYS to the older adolescents, 18 to 20-year-olds. There's also a bill, and has been a bill for a couple of sessions, an act to promote public safety and better outcomes for youth that we support. And finally, the legislature could consider legislation to remove healthcare services from being within the control of correctional departments entirely. That's especially a consideration on the adult side, given a long history of challenging and poor outcomes for health outcomes for adults who are incarcerated. A few recommendations to DYS. In the meantime, while the legislature is considering this bill, DYS should codify this community standard of care into both its regulatory framework, and even they could tomorrow pass a policy that would do that. This is in line with what they're already doing. DYS should continue to work collaboratively with Mass Health to fully implement the Consolidated Appropriations Act and Section 1115 waivers. And DYS should end the indiscriminate shackling of young people in healthcare settings. DYS should use PREA, the Prison Rape Elimination Act, data to inform and educate staff around issues of safety and trauma within DYS facilities, with a particular focus on disparities between LGBTQ youth and non-LGBTQ youth. And finally, DYS should ensure that the lived experience of young people in DYS custody are taken into account in doing policy development. Towards the adult carceral system here in Massachusetts, these are some longer-term recommendations, but I think are really important to bring into the conversation. One is to consider shifting the RFR process for healthcare away from this capitated model of payment, which can incentivize sort of rent-seeking behavior and not strong health. They should consider contracting with nonprofit health providers. There are ways to write that into regulation and policy, and to establish and solidify this community standard of care via policy and regulation. Right? It's already mentioned, but to make sure that if DOC is going to do that, that they use actually a really strong community standard of care, not a watered down version that's only making reference to other carceral populations. The adult system should ensure they're working collaboratively with Mass Health to fully implement the federal changes and the 11 Consolidated Appropriation Act and Section 1115 waiver. And I'm not trying to suggest that they're not, but I know that there's a lot of work there. They should continue that collaborative work. And ultimately should design and implement a system to identify eligible juveniles, and that's a term of art within the CAA that can go up to 21 or up to 26 for the purposes of making sure they're fully compliant with the CAA. For mass health, it's important to elect the option within the CAA Section 5122 to extend Medicaid coverage services to pretrial individuals. This is something where the state can opt in or not, and we think it's really important that that we do that here in Massachusetts. To create a continuous care model and continue to support people both in the carceral setting, but especially as they return to the community. To ensure enrollment in mass health and managed care at release. We have heard stories of young people who have aged out of DYS and had a hard time connecting and getting their mass health in place. There is a switch, even though young people at DYS are on mass health, there is an administrative burden as they age out to switch the type of mass health coverage they have. And we've heard some stories of young people who have not been able to do that. And certainly to develop a system to monitor progress towards the CAA and Section 1115 waiver implementation, right? This is something new and important. It's worth noting in the current federal environment, there's a fair amount of unknown on whether these Section 1115 waivers are going to continue. We certainly hope they do. And we know that that the National Sheriff's Association is on board and has been pushing the Trump administration to keep them in place. So we are appreciative of that. Finally, and this is my last slide, towards academics and researchers, we think that it's really important to continue to research and compare other states' governance and policy structures within this juvenile justice system healthcare framework, right? To further understand where does Massachusetts sit compared to other states, and especially looking at the third recommendation, to look at outcome research for young people who are entering DYS healthcare network and compare those results to youth from the other states, right? I mean, we care about having a robust system in place, but ultimately we care about that because we care about having strong health outcomes for young people and making sure that researchers are looking at those outcomes as well. And finally, as the second recommendation says, to continue to center the voices of young people with direct lived experience in the system in future research efforts. Okay, with that, I'm going to turn it back to Leon to introduce Rep. Schwartz. Thanks so much for joining.
Yeah, thank you so much, Josh, for that really thorough run through of the report. Again, just another quick reminder, if you look in the chat, there is a link to the report where you can go and read and download it as well, or go to www.cfjj.org/just-healthcare. But now I have the privilege of introducing a member of the Massachusetts House of Representatives, Dr. Greg Schwartz. Dr. Schwartz represents the 12th Middlesex District. He is a native New Yorker who received his bachelor's degree in government from Harvard College and both his MD and JD from Yale University. He worked as a primary care physician in the Boston area for almost 25 years, so he brings a wealth of experience. Prior to becoming a state representative, he was a Newton City Councilor for many years. He has 2 children and lives in Newton. And Dr. Schwartz will provide some thoughts on a piece of legislation he sponsored that addresses the community standard of care that Josh talks about. So, Dr. Schwartz, the floor is yours. Welcome.
Well, thank you so much, Leon and Josh and Sana, for all your work and your partnership in these important issues that you were just discussing. I hope you all won't hold the New Yorker origin against me. I have been a very honorable Patriots fan, so hopefully that'll argue in my favor. But I've been an observer of DYS and our correctional system as it regards to juveniles for a long time, and I've been very, very impressed with the leadership and the quality of care that DYS has provided to our youth. And I'm just so encouraged by the report that you just presented, which includes the high marks that the residents of DYS facilities have youth have given it in its healthcare provision. And essentially, as Josh was saying, this legislation is trying to address not a bad thing. Actually, it's trying to celebrate a good thing, which is a nice position to be in sometimes. Sometimes it's rare, but it's always nice when it's the case. And in this case, what I'm hoping to do with this legislation is simply, which is, by the way, it's been renumbered as H285 and Senate 169, and it's been referred to the Committee on Children, Families, and Persons with Disabilities, and does not yet have a hearing date. But what this legislation simply does is it takes what DYS is already doing through its its RFPs and RFR and trying to codify the high level of standards that it's been following. Certainly in these good times and recent times, the leaders of the program, the administrators, the administration have been obviously producing and providing tremendously popular and high quality care. We just would like that to be the standard in the law, so that this is maintained throughout times that may change, obviously, with different leadership. Just to be more specific, outside of the intuitive, obvious, I would say obvious value of providing comprehensive, qualified professional care to young people. The study, as you presented, shows that under the current setup, DYS provides both through Medicaid, the Mass Health Program, through DYS funded health, through contracted care with nonprofits, a terrific level of high quality integrated healthcare for young people, including substance abuse treatment, urgent care, and comprehensive preventive care. And our children, wherever they might be in our society, deserve nothing less. The American Academy of Pediatrics sets the standard. This bill would call on DYS to have to follow standards equivalent to the American Academy of Pediatrics Bright Futures Guidelines for Health Supervision of infants, children, and adolescents. So I'm hopeful that this is something that we can get onto the books so that we can continue to have DYS provide this level of care. I don't think that there's any opposition from DYS that I've heard. So with your help and your advocacy, I think that we can move this along. And I'm a new legislator, so it may be too idealistic, but I think that this kind of legislation is really non-controversial and shouldn't create any kind of clear opposition. So I welcome your partnership. I appreciate all that you do on behalf of our DYS youth, and I would be happy to be available for any questions or any comments from the audience today or any time in the future. So thanks again for welcoming me.
Thank you so much, Representative Schwartz, for making time out of your very busy schedule to be with us today. And I'd like to just draw everyone's attention to the chat, where there is a link to a fact sheet which goes through and gives details on the piece of legislation that Representative Schwartz just spoke about. And with that, I'll pass it back to Josh for the roundtable discussion that we're going to have with our experts this afternoon.
Thanks so much, Leon and Rep. Schwartz. We really appreciate your leadership on this. It's my real pleasure to introduce Dr. Destiny Tolliver and Dr. Elizabeth Barnard. I'm going to quickly say a few words, but you should look them up because they're perfectly placed to speak about this issue and extremely well qualified and fabulous people. Dr. Destiny Tolliver is a pediatrician and health services researcher at Boston University's School of Medicine and BMC. She attended Yale undergraduate before earning an MD at Morehouse and completed residency and chief residency at BMC and Boston Children's. She's completed also a research fellowship at the National Clinician Scholarship Program at Yale and returned to Boston as assistant professor of pediatrics. Her research focuses on identifying policies and programs to improve the health of children and families impacted by the criminal legal system. Welcome, Dr. Tolliver. Dr. Elizabeth Barnard is a pediatrician and associate professor of pediatrics at UCLA, specializing in pediatric care of youth within LA's juvenile legal system. Dr. Barnard's work is rooted in the principle of children's rights and social action. Among other things, Dr. Barnard serves as chair of the Juvenile Health Committee of the National Commission on Correctional Healthcare and on the Commission's Board of Directors and as Associate Director of the Academic Pediatric Association's Health Policy Scholars Program. Welcome, Dr. Barnard. I'd like to ask just to hear from both of you, what in your experience as practitioners in this field are the most important needs that you see for young people and young adults in confined settings for whom you're providing care? Whoever unmutes first, please.
Well, hi, everybody. Thank you so much. I unmuted to say, Destiny, would you like to answer this question?
Sure, I can start off and then maybe pass it to you. So I don't actually care for kids who are currently confined. I do my primary care at Boston Medical Center. And so I see kids after they have been incarcerated or confined. And I see them before the rest of the kind of aspect of care that kids experience. And I think that gives a different lens to things where you see that all of the issues are the same across the board. A lot of these kids have a lot of challenges with their mental health, with their physical health. And I think the mental health aspect of it is the one that has been the most challenging and the most kind of prominent in my patients, at least, who have been involved in the system. And that's everything from accessing therapy to accessing medications to making sure that they have the right medications, being able to kind of monitor how those are working for them, and then hopefully getting to a place where those are allowing them to kind of succeed in other aspects of their lives. And so I think that part of care is the biggest spectrum that goes across all settings for these kids. And I'll pass it to Liz.
Thank you. So my clinical experience inside the walls of our youth detention setting really do reaffirm what the national data show. The kids in the juvenile justice system have extremely high mental health needs, which also aligns with what Destiny's saying. So these kids often have very high levels of exposure to prior trauma. Half of youth have had exposure to 4 or more what we call adverse childhood experiences or extreme traumas like loss of a parent or food insecurity. And not surprisingly, 3 of 4 kids, if they were all have thorough assessments, would meet at least one criteria for psychiatric diagnosis. The other needs that are very high are the sexual health and reproductive health needs. So 1 in 3 girls who are incarcerated have been pregnant. National data show 12% of kids incarcerated are expectant parents, and the rates of sexually transmitted infections are tenfold for youth who are incarcerated compared to non-incarcerated peers. So delivery of healthcare is extremely important. Also, the infectious disease risk and access to vaccinations and catch-up vaccinations is vital.
Thanks. I'm curious if you could speak a little bit about what the community standard of care means and how important that community standard is for healthcare for young people in confinement.
Yeah, it's funny. As you were talking before, I kind of looked over at my shelf over here, and I have my Bright Futures with me. This is the little handbook. There's also an actual book. But so our community standard of care is something that is developed by the American Academy of Pediatrics and a variety of other organizations, and then kind of distilled into this. And through it, we have a certain schedule at which kids are supposed to come in for their checkups. At those checkups, we do all of their measurements, their weight, their height, things like that. We talk about healthy eating. We talk about healthy behaviors and activity. We screen for a variety of kind of social needs and whether there are other risk factors that are at play in their lives. We talk about healthy relationships. We do their vaccines. We screen for STIs, like Liz was mentioning. We talk about mental health. And through those things, we also refer people to specialists as needed. We start and monitor medications. So all of those things are kind of the standard of care of what we do. And it's all kind of based on some of these documents that you refer to in that report. And it is really important to be able to make sure that these kids have everything that they need to grow and develop and thrive as much as possible.
So Destiny, I love that you have your book on hand. So the community standard of care, it's essentially it's our evidence-based guideline. I'm sure, as Dr. Schwartz knows very well, these are the guidelines. They're kind of like your Bible when you're practicing medicine. This is what the research has borne out, and so this is how you make your clinical treatment and diagnostic decisions. And the Bright Futures guidelines are so important because they're the guidelines for preventive care and health promotion. So how do we help a child who is sick, but also how do we help a child achieve wellness and help them transition through a healthy adolescence and become a healthy adult? Josh, you gave such a great overview of juvenile justice healthcare, and it's quite complicated, but your point about deliberate indifference, that's the current standard. So that means basically the current standard is that I cannot be medically neglectful when I'm in a juvenile justice setting. So imagine if you brought your child to my pediatric office, or you brought your child to Destiny's clinic, or your niece or nephew or your grandchild, and you said to me, this child is having frequent nosebleeds, which often suggests a nasal polyp, referral to an ear, nose, and throat doctor, a cauterization fix. And I say, well, doesn't look like your child's dying. End. I mean, that's what deliberate indifference is. We actually need to make the kids be healthy, because that's why they're in a juvenile justice facility, to rehabilitate. So it's the community standard of care that we follow that allows us to use the collective knowledge of evidence-based science and all pediatricians to figure out how to do this for all kids.
Yeah. I just wanted to add that I think one thing that I've gotten from my mentorship from Liz and from conversations with people is that we talk about kids who are confined as though they're not kids. And I think if we can always remember these are children or adolescents or young adults, these are people in the care of the world of pediatrics, and so they need to be treated that way. So just because someone's incarcerated doesn't mean that they're not a kid, and doesn't mean that they don't need the same level of healthcare and compassion that everyone else does. So kind of codifying that, I think, makes a lot of sense for them.
I have a question, a national question, which I think I'll give more towards you, Dr. Barnard, and a Massachusetts question a little more for you, Dr. Tolliver. How does, on the national side, how does Massachusetts sort of sit, both in terms of its structures and even outcomes, if we know health outcomes for healthcare for confined youth when compared to other states or even other countries? And then just a preview for you, Dr. Tolliver, what do we see that looks different in terms of structures and outcomes between youth and adults here in Massachusetts who are confined?
So I agree with Representative Schwartz that there is a lot to celebrate about what you guys are doing in Massachusetts and the structure that DYS has set up, and Josh, we've looked at the contract together. I agree that the contract that's setting up the provision of healthcare is very strong, but codification would be very valuable. So structurally and in terms of governance, and the fact that you have Mass Health and kids can have continuity of care, and Massachusetts is positioned to be a leader in these Medicaid reentry waiver demonstration project. It's so exciting, and the country needs Massachusetts leadership a lot. But stepping back as a researcher, I have to give you a very honest answer. I don't know how Massachusetts actually fares when you're talking about the health outcomes of kids and the delivery of healthcare in the facilities, because I am not exaggerating when I tell you we have no data on this. I don't know what's happening in the other facilities in California besides healthcare. The walls of the facilities keep the kids hidden, but they also keep the healthcare hidden. So your point about it's the health outcomes that matter, I absolutely agree. And we don't have data showing this.
Yeah, and I think it's the same thing for thinking about the difference between the adolescent versus the young adult outcomes. It's the data is really just very limited. And so I love that in the presentation and the report, you're calling for more data, more conversations about these things, because we can't make decisions without actual data. And even the fact that you were able to get the interviews that you did, I think helps to shed a lot of light on these things. I think just kind of anecdotally, because that is the data that we have, hearing in this report that youth are pretty happy with the healthcare that they're getting, I think is huge. I know in other states where I was talking to advocates at, like a couple of years ago, the adolescents were saying that they were having a lot of difficulty accessing mental health care, accessing whatever their needs were in kind of an urgent manner. So it does sound like we're doing better there. But the difference between young adults or adolescents and young adults, it sounds like a very striking one, where there's like a light switch. You turn 18 and suddenly you're not able to access those things. And so making the policy change to bring those kids into the juvenile space seems like a huge opportunity to improve their health as well. But then we should measure it with good data so that we can actually report back on it too.
Thanks so much. My last question to you, and then we're going to pass it to Leon to open up for questions from the audience. So feel free to, everyone else, drop questions in the chat or raise your hand after this question. And also, thank you, Rep. Schwartz. You did offer to answer questions. So if you have questions for Rep. Schwartz, we'll spotlight him as well. I gave a bunch of recommendations. The report has a bunch of recommendations, but from the two of you, what next steps would you like to see from state and system leaders in the area of health delivery for young people who are confined, and not just confined in the broader juvenile system overall, but a relatively small number of youth make it to DYS confinement. So I just anything else that we should be thinking about.
I have like a dream of getting discharge summaries essentially when people are leaving confinement. So in the community, when someone is in the hospital, at the end of that time, there is a document that says why they were there, what they were treated for, and what the kind of ongoing things to do are for the primary care provider. And I could imagine that for someone leaving confinement, since so many of those kids haven't had their primary care appointments recently or their vaccines or various other things beforehand, that there's healthcare that was received there that would be helpful to pass on to their providers. Or even just getting kind of that notification from the system that says your patient was incarcerated, they're coming back out, they're going to have an appointment within X number of weeks. We just wanted to let you know, I think would be helpful from a systems perspective to improve the coordination of care there. And then I think really using processes like that to also set up systems for recording the data that would be helpful from the health perspective, but also from the legal system perspective, because I imagine that they want to look at recidivism, and I imagine that there are ties between recidivism and some of the other access to care issues, and we're just not able to look at those things right now. I'll hand it to Liz.
Thank you.
I think that you have laid out an exceptional policy agenda for Massachusetts. So I hope that your state and systems leaders really heed your advice and recommendations. I think that the codification of the community standard of care is a really important next step. I agree that the challenge is fragmentation. And one of this, Brian Stevenson uses this word proximal, like being proximal to the kids and their families. Josh, you use the term lived experience. There's going to be there's a lot of confusing policy language about this Medicaid reentry stuff, and federal policy environment is very confusing, but actually really listening to the mothers and the fathers and the kids. Were you able to make that mental health appointment? Did you get your substance use medicine filled at a reasonable time? What's it actually like on the ground? And setting up those communication loops, I think is really key. You had also asked about other countries. So there are models in terms of shackles. There's a facility in Ireland that uses the children's rights approach, and the kids are in their normal clothes, their street clothes. So when Massachusetts is ready for transformation, know that there is other ways to approach youth justice that are more humanistic and more healing.
Thank you so much, both Dr. Tolliver, Dr. Barnard. I'll pass it to Leon and again, open it up for questions from the audience to either of our guests as well as to Rep. Schwartz.
Absolutely. I just want to reiterate again, thank all of you so much, Dr. Tolliver, Dr. Barnard, Dr. Schwartz. We've just had a wealth of knowledge and experience here in talking about this important issue. And so I'll open it up to questions from the audience. Please feel free to click on the react and hand raise button, and we'll be quick to call on you. Everyone was so blown away that but we do have applause that I could not agree with anymore.
Looks like Rep. Schwartz has a question or a comment.
If I may be so bold, since we have Drs. Tolliver and Barnard here, I'm intrigued by the last thing, or one of the last things one of you said about the discharge summary idea. I think that was Dr. Tolliver. Sounds eminently reasonable and incredibly useful, I would think, to the physicians on the outside, pediatricians and adult physicians when the youth would be released. I honestly don't know what the current availability of the data from healthcare provided within DYS is. Perhaps you could educate me a little bit more on that, or if Josh knows more, I'd really be interested in hearing about what is the current state of that handoff, or even just availability of the data, even if there's no particular handoff, if it's available when somebody does end up in a pediatrician or adult doctor's office later and needs that information. Is there any records given to the patient themselves, the youth resident themselves? I'm just curious.
Yeah, I would say in my kind of limited experience, there has not been, but that doesn't mean that it doesn't exist. It's just, we know that these systems are fragmented, and I imagine that things are different across the different hospitals, across the different regions that DYS operates in. And so I would love to learn more about what the processes would be for changing this and for getting some of that data. And if we could work on that, that could be the next piece of legislation, or CfJJ if we wanted to work on something together. Because I think even understanding the answer to that question better would put us on a good pathway towards improving care for these kids.
I want to invite one person who actually has her hand raised already, Dr. Christina Baugh, who practices here in Massachusetts, and may be able to answer that question as well. But you also raised your hand with a question, so please both go ahead.
Oh, I just wanted to make a comment. Yes, I'm Christina Baugh. I'm the medical consultant with DYS, and I work closely with the Director of Health Services. And yes, that is a thing that is high on our radar. Just coming into DYS a year ago, I was receiving patients from DYS and getting summaries that may or may not had enough information. And so what I've learned over the past year is that there is a discharge summary that is given to the patients or the parent, to the youth or the parent. And we ask for permission. How much can we share with your provider? Because some people find there is stigma with having been incarcerated and may not want all that information, going freely back and forth. So that's a line that we are walking. Another thing is just in regards to reentry and getting appointments. That's something we're working on very hard to just develop a good, robust transition process along with the CAA, act that we have now to help with some of those actions that we're trying to implement, but we really are trying to find out, what appointments are you getting, trying to identify those 90 days before, 30 days before they're leaving, and then follow up to find out if they're able to get into these appointments. That's can be an issue too. Because once they leave DYS, then health services, we no longer really have the connection to contact them and say, did you go to the appointment? So finding ways to see perhaps maybe through mass health claims, can we find out if they've gone or not? These are things that would be, a way. But that's all I have to say right now.
Thank you so much, Dr. Ba. Dr. Schwartz.
That's wonderful. Thank you so much for being, able to answer that question, Dr. Ba. I guess it just begs another question in my mind is, or at least it was raised, do we keep, or does DYS keep kind of summary data on the diagnoses and conditions, and potentially some of the outcomes that the other folks on the call were referencing internally? And is that something that could be available at some later point to compare with, to show how we're doing compared to other states?
Yes, they do have an extensive medical charts, that they keep for decades. So this information is there. And there is a discharge summary that has some information about vaccinations that were given or medications that they leave with, but not the details of everything that happened throughout, the management of whatever the issues were.
But I mean, just as I'm sorry to follow up though, does DYS keep any, their health, division keep any kind of cumulative data, de-identified, just that, what the conditions were, what were some of the treatments?
We do have some, there is some data that is there, such as just knowing the most common illnesses that were like asthma or obesity or overweight, so there is some information that we do have. So yeah, there is some information, but just really putting it all together, it's so for something to be published is not something that we've done yet.
And I imagine there's costs associated with doing a more robust kind of analysis or at least maintenance of that data that potentially would be, essential if you were asked to do more.
Right. Yeah. Something that we are always considering, and it would be a great idea to look at it.
That's great. And I just one last thought. I mean, so if we were able to, I guess there's release before 18, right? There are children who are confined and then released before, right? So do we have data? Can we do any data on recidivism before they reach, age out, after release from DYS? Are there any? I imagine that CfJJ has more data on that as well. I apologize if I'm showing my ignorance.
No. It'd be interesting. So there are certainly young people who receive a grant of conditional liberty. They are committed. They have a period of treatment in a secure space. And then as they begin to do well in advance, they then are returned to the community. It would be interesting to be able to track these sort of health outcomes in addition to just whether the young persons remain in the community or ended up going back in. Josh, did you have a thought there?
I was just going to say that DYS does have an annual recidivism report, but it's I've not seen health integrated into those. So great. I was going to put that same. There's now a link in the chat to those reports.
Because you could imagine that there would be certain diagnoses or treatments that, if they were continued in the outside after release, or not continued, that you could show a delta there that would enhance the argument for that transition being better managed.
Absolutely. I think we have time for one more question. Colleen Cormier, go ahead and unmute.
Hi, thank you. I actually just wanted to offer some insight into, I work in the detention setting. And so as far as the continuity of care and communication with the primary care provider in the community. So I receive that information when I'm told that a kid is coming in, when I speak to the parent. So I get a copy of their most recent physical. We use the MIIS to look up vaccinations. We then, of course, put any vaccinations that we do put into the MIIS. And I also fax to the primary care a copy of my administration record in case their system, I don't know, because we don't have an electronic medical record. So I'm not sure how they talk to each other. Same with labs, any labs that I do, I'll share with the primary as well, especially if it's like a med monitoring situation. And of course, I'm in communication with the parent. So there is some, sort of just kind of standard communication between the primary in the community and then in the juvenile detention as well.
Thank you so much. And thank you all so much just for the robust conversation on this issue. Certainly a lot of great work ahead to build upon this information and make some very positive changes for our young people. But we are past 2 p.m. I just want to thank again Representative Schwartz, Drs. Tolliver and Barnard, and all of you for attending. And again, please go to cfjj.org to download a copy of the report. And with that, I thank you so much, and I wish you all a wonderful afternoon. Take care.